Good afternoon. I'm Suzanne McDermott. I'm in the Department of Environmental, Occupational, and Geospatial Sciences here at UNI, and I'm very proud today to introduce our speaker, Sabo-Attwood, who is Dean at the University of South Carolina Arnold School of Public Health. I spent 30 years of my career at the University of South Carolina, and we overlapped a little bit. I was at the medical school. She was at the School of Public Health, later went to the School of Public Health, but we overlapped for a few years. Dr. Sabo-Attwood was born and raised in Connecticut, but she left to go to the University of Florida, where she got her PhD in environmental health science, toxicology. And then she spent her early years doing a couple of different postdocs, went to the University of South Carolina from 2006 to 2010, and then returned to the University of Florida, where she'd gotten her PhD. And there she rose through the ranks, became the chair of the Department of Environmental Sciences, and also dean of diversity and wellness on that campus. She's had really an illustrious career doing basic science. I always thought of her as an ocean person. When I knew her, she was working in field related to NOAA, the National Oceanographic Institutes, and now she's doing work related to different kind of water, wastewater. So she's run the spectrum of different kinds of science, but she's a real bench scientist as well as a applied scientist. So we're very pleased to have her here today, and I'll let her take it away from here.
Thank you so much for the invitation to be here today. Thank you, Dean, as well. Nice to see you again. I have had a wonderful day here. So I've gotten to meet a lot of the faculty and staff and a wonderful discussion with PhD students. So thank you for all the discussion and the time to spend with everybody today. So I was asked to come and talk about wastewater today, which is kind of my newest venture. But as Suzanne mentioned, I've done a lot of different things in my career. Certainly wasn't a 10-year-old going, I want to be a public health professional one day. That did not happen. What I wanted to do was fly fighter planes. And I was probably influenced in the 80s by the original Top Gun movies, which have come back full circle. So I do that. But what I did is I got a degree in genetics and I worked in a clinical lab for a number of years. And back in that time, we were actually looking at chromosomes, were stained and banded and using them really to diagnose different genetic diseases. I went to grad school, and as Suzanne mentioned, I got really involved in aquatic systems. I got my doctoral degree in aquatic toxicology. So I was wading into wastewater at that time, 20 or 30 years ago, in a different capacity. So we were looking at effects of wastewater on the reproductive capabilities of aquatic species. I then did a postdoc at University of Vermont, and I got expertise in respiratory toxicology. I still do both aquatic and respiratory tox. And then really in the last decade or so, I really gotten into some more applied research and doing work with like migrant farm workers, looking at environmental exposures, leading educational interventions with those communities. The wastewater story, or the wastewater epidemiology story, really got started for me during COVID. And I think this happened for a lot of folks. I think what COVID did was make wastewater-based epidemiology more of an acceptable thing to do in the United States. In other countries, people have been doing wastewater-based epidemiology for decades and doing it well. In Europe, in Australia, but people started getting on board and doing this. So I was approached, I was at University of Florida at the time, and the leadership came to me and said, Sabo-Attwood, we need you to set up a testing lab for people. in 10 days. Can you do it? And I was like, I don't know, but we tried and we did. And for about a year, we were running all of the swab testing for COVID until hospital and the medical folks could take that over. And then we shifted to tracking SARS-CoV-2 in wastewater. And we did that in a number of ways. We did it in the town of Gainesville, Florida, where the university sits. We did that in dormitories on campus, and we did them in some other smaller communities in Florida as well. We've also done some other studies I'm not going to talk about today. We're trying to use wastewater as an indicator of pesticide exposure in farm worker communities. We have other folks in the department who are doing all the infectious disease stuff, looking at measles, which you might have seen South Carolina on the news for the number of measles cases we now have in the States. But today, what I'm going to talk about is some of the work we've been doing over the last couple of years where we're quantifying illicit drugs in wastewater across the United States by focusing on some target cities. So let's all kind of get on the same page about what wastewater-based epidemiology or what this framework looks like. Everybody here in this room today used the restroom at some point. When you did that, you excreted certain molecules into the toilet, which end up to water streams. Okay? And so what we can do in wastewater-based epidemiology is we can sample those wastewater streams, typically at a wastewater treatment plant where all of the sewage goes to. And we can process that wastewater and we can look for markers of things. We can look for SARS-CoV-2, we can look for opioids, we can look for measles, virus, whatever it is we want to target. And then we can take that data and we disseminate it to people that we hope will use it for something useful in public health. And I call that area kind of knowledge or action. So this is the entire framework. Why is this technology or this tool useful? What are some of the benefits of this? Well, probably one of the biggest benefits is that it's really rapid. And so if you're talking about opioid overdose deaths, if I want to get all of that information from the CDC, there's a lag time of several months before I can access that information. But I can do measurements in wastewater to understand how much fentanyl is circulating in a community same day. So we call this kind of near real time, and that's why it worked well during COVID. We could take measurements of wastewater, process those samples, and look for the SARS-CoV-2 virus. And it was really a measure of what was happening right then in the community. That's some of the power of it. If you are measuring things in wastewater before they happen and you start to see an uptick in them, a lot of people can consider this as a really good early warning system. So you're kind of getting ahead of something before it becomes a really big, major problem. It's fairly sensitive, and a lot of that has to do with the technology that we use to measure the molecules. So whether it's by chemistry or mass spec, or whether it's by some PCR-based method, the technology we have is able to pick up things at very small amounts. Measurements that we're doing represent not individual people, but a community. Okay, so we're getting population level measurements in this approach. Does not involve direct interaction with people. Some people may consider that a benefit. And it can be used for broad community assessment or subsection of the community. And that really depends on where you're doing the sampling. If I'm sampling from Alachua County over there, it's in the middle of Florida, and there's just one wastewater treatment plant that services that entire community. You can take wastewater samples and get a snapshot of what's going on in the community. Now, common than not, we're doing is sub-county level measurements. And so say a county has 3 or 4 wastewater treatment plants that represent that geography. I can sample from all 4 of those wastewater treatment plants. That will give me an indication of what's happening in subsections of the community. And then lastly, we can actually get pretty granular if we go into the sewer network. We did this during COVID in the dormitories. We can actually go and pull wastewater where water is coming out of a building in the sewer network. So you can kind of go in manholes, if you will. You know, you've seen those in the streets, and we can do sampling there. So that's a more granular level of sampling. And that community is tied just to that particular dorm or building, wherever it is you're sampling. Most of the work I'm going to talk about today is going to be at the sub-county level for cities. We've all probably heard about the opioid epidemic. Anybody not hear of that? Fentanyl is a opioid that has caused us huge problems in this country, in particular over the last several decades. The opioid epidemic can be described in 4 waves. So a lot of people in the field describe it in this way, where back in the early 2000s, we were prescribing opioids. And that sort of got away from us a little bit. And what happened was we tried to put policies in place to do less prescribing, but then people were looking for cheaper alternatives to that. And so that ultimately pushed us to wave 3, which is where we had synthetic, illicitly manufactured fentanyl onto the scene. And so that's where you see that blue line. That is, I have a cursor here. Here we go. Can you see that? And that's where you have this real big uptick in deaths associated with fentanyl. Now what's being described as a 4th phase, and what's different about the 4th phase is that we're now looking at a lot of mixtures. So in the 3rd phase, it was a lot of single-use fentanyl. And now we're dealing with fentanyl mixed with, you know, name your favorite drug of choice there, whether it's xylazine, whether it's amphetamines, you know, what have you. And so that's now causing complexity with trying to battle this opioid epidemic. Lots of people had died. We hear about this in the news, overdoses of fentanyl. Opioids in general have caused about 800,000 deaths. Most of that, about 3/4 of that, is due to fentanyl in some way. So we got really interested in trying to employ wastewater-based epidemiology to try to track opioids and other illicit drugs across the US, so we can compare across cities, so we can see sort of what's happening regionally. And the second piece of that is that second part of the wastewater-based epidemiology framework, which is we get this data into the hands of people who could use it sort of in the public health. One of the ways we got into this was at University of Florida, where I was at the time. They started having some conversations with Linda Kotler, who's the PI of a coordinating center called the National Drug Early Warning System. So this is kind of a center funded by NIH NIDA. And what they are all about is collecting data from across the US that really represents early surveillance of what's going on with drug trends. And so their whole deal was to implement these novel surveillance tools. They didn't know anything about wastewater-based epidemiology, but they were implementing things like rapid street reporting. And so this was deploying people into different cities at any given point in time and doing interviews with drug users to try to get ahead of what they were using. And so it was really valuable information to try to really be on the streets to see what's circulating, what are the terminologies people are using, what are the new drugs called, all of that stuff. We've implemented programs where they mine Reddit for conversations that happen to try to, get at what are the new things that are emerging. So a lot of the early warning stuff is to try to get ahead of things before they're a problem up here, like we see with fentanyl. We can do interventions early on to try to keep it from getting that space. So that's kind of the big idea of induced. So we were fortunate to get some funding, supplemental funding to this center to be able to add wastewater-based epidemiology, sort of an early warning tool. I have QR codes there. They send out briefings if you sign up, and so you can get briefings from Induce. I think it's weekly now, about what's going on in their center and drug trends. So when we first started this, my disclaimer is I am not an expert in illicit drugs. I know the toxicology of them probably more than anything, but we had no methods or any there ways to measure this. So we had sort of three objectives in this initial study. And the first was to find a way to collect wastewater samples from across the United States and process them for different drugs, which means we had to come up with methodology, chemistry-based methodology to be able to quantify them in a rigorous way. The second piece called data harmonization. And we're kind of in that process now. I'll share a little bit of data with you. And so we have these wastewater measurements. We want to be able to ground truth those and see how those compare with what I'm broadly calling health data. So overdose deaths, naloxone administrations, EMS data, that sort of thing. So I'll talk a little bit about that today. And then the last piece is the data dissemination piece. So be able to provide this data to stakeholders so that they can put it to good public health use. I will say that part has probably been the hardest part of this whole operation. And we'll talk a little bit about some of the challenges we faced in that area in just a little bit. So the overall study had 8 mostly large cities across the US. I'm not going to be able to name those cities today. So one of the challenges in working with opioids and other illicit drugs is cities do not want to be identified. And so we keep to that deal that we've made with them. But within each city, we have a number of different treatment plans. And so back to that idea of kind of regions within different counties of the city. So we were collecting about 40-ish samples every week. At the time, we have about 55 drugs now. We had 70 drugs. So we developed methodology that allowed us to measure those 70 drugs in one go, in one sample. We did rapid turnaround of a week. I don't know if I'll ever promise that again. It's it's a lot to do things around weekly, but I also think that's some of the power of this tool is to be able to get data back, quickly to our stakeholders. And who were our stakeholders? So I worked with a team of 30, 40 people, and they were wastewater engineers from the city. They were people from the departments of health. They were epidemiologists, they were toxicologists, they were, community people working in the communities, and city officials. Can't be named as well, but a pretty big team that we're working with. These are all the drugs that we were quantifying by mass spectrometry. So this is our method of choice, very sensitive way to quantify these in wastewater. I'm certainly not going to go through all of these, and so I've sort of binned them for you. So we're looking at things like opioids, of course, fentanyl, the big one looking at. But one of the other, or some of the other ones that I've highlighted are nitazines, for example. And what was sort of cool about working with Endues is they were hearing a lot of chatter about nitazines coming on the scene. And so we could put those easily into our method and be able to measure those. So another type of potent opioid. Opioid treatments, we're really interested in looking at what information we can garner from the treatments for opioid within a community. So looking at naloxone, for example, which is that treatment that you got to get quickly if someone is ODing from fentanyl. I think you need to get it within like 2 minutes or something like that. A whole bunch of stimulants, methamphetamines and cocaine and some other drugs like that. We always look at some prescription drugs. A lot of times they stay pretty stable, so we like to be able to see that. And then we have this other category, I'll just mention one like xylazine, which is a veterinary tranquilizer. But people started mixing that about 2 years ago and it caused all sorts of really potent effects. And a lot of the overdoses that we started seeing were from that mixture. So we looked at that as well. This was the pipeline that we set up for how our shop operated. So what we did was we had a cooler kit that we built out that had all of the water bottles and the chain of custody forms, and we would ship this kit every week out to our partner cities, and they would fill it with wastewater. And the poor graduate students who had to actually deal with these samples that, remember, these are sewage samples before they're treated. So you can imagine what some of them looked like, but and it was just sort of shipping back and forth. It worked really well. I will say, for anybody who wants to get into this is a costly part of the operation, to be shipping hazardous water overnight from faraway places. But it did work. And once we would get those samples in, we would filter them and process them with something called solid phase extraction, but it's just a way to start pulling away the noise so we would get a more pure sample, to be able to then detect drugs by LC-MS, which is mass spectrometry, pretty sensitive chemistry method that allow us to distinguish all those 70 drugs in the same sample. One of the, we're not going to go through all these calculations, but just to let you know how we normalize the data. So we're measuring all these drugs in each sample, but there's two important pieces of normalization that we have when we get to the end game here, which is consumption rate. Those units are in milligrams per day per 1,000 people. So everything I'm going to present to you is based on consumption rate of drug X. The two important things to know are we have to normalize this to the effluent rate in each wastewater treatment plant, which is a staggering amount of water. You can see the numbers up there. Like, these are big cities, so that's how many liters per day are flowing through wastewater treatment plants. But you have to account for how much water's flowing through in order to normalize these concentrations to each other. The other normalizing piece is the population. So how many milligrams per day per 1,000 people, you need to know how many people within that catchment area. So you may have a wastewater treatment plant with this much norfentanyl in it, and this is, 100,000 people. And then you have the same amount over here, but now this is 1 million people. That means two very different things, right? So we do take into account normalizing for flow rate and population. These are not calculations I made up. People that have been in the field longer than me present data in this way.
Is this data ever presented with standard deviation?
We can do that. Yeah.
Would that solve the problem of the population size?
It can somewhat, but a lot of times we're not getting multiple samples per wastewater treatment plant per day, just because there'd be no way to process that many. So we can, once, if we get all the data sets and then we average across. It's a pretty standard way for people to do it. The other piece that I want to mention here that we take into consideration is whether we use parent molecule. So fentanyl is the parent molecule, right? Or the metabolite. So if I consumed fentanyl, what I would excrete would be primarily norfentanyl in my urine, 77%. So many of these cases where we understand the metabolic process of these compounds, we tend to use the metabolite in our analysis. It makes sense to do it that way. One thing that it does help us with somewhat is you can have fentanyl in wastewater systems because people consumed it, and you'll have primarily norfentanyl, but you can have dumping that may occur, just directly of fentanyl that wasn't consumed at all, right? And so by looking at the metabolite, we know at least that's coming from fentanyl that was. And so when we can, we like to use the metabolite. I think it's a more accurate marker of consumption rate, if you will. For some drugs, like xylazine, because it's a veterinary tranquilizer, typically used in large animals, we have biotransformation information on horses of what metabolites may be made, but we don't really have that for people. So then it becomes harder. And so in some cases, we do need to default back to the parent molecule in that case. Hope that makes sense. Yeah. And so I'm just going to share some snapshots of the data. This is a massive data set. We did this for over a year. In some cases, we have 2 years of data weekly. So it becomes a little bit unruly. We're still sort of sorting through it, but what you have along the x-axis at the bottom is 4 cities, and those cities are called West, Southwest, Midwest, and East, as much as I can give you. And what that means is that they're in those regions of the US. Letters are the different catchment areas within a given city. So in the West, we just have 1. In the East, we have 3. In the Southwest, I think we have 13. And Midwest, we have 4. Okay. On the left-hand side, I've binned those drugs for you again, opioids, stimulants, so forth. This is on a log scale based on the consumption rate, and the more blue something is, dark blue, the higher the quantity that is, or the consumption rate is in that given area. If it's yellow, it's pretty low comparably, or if it's white, we didn't detect it. Okay. So I'm going to point out just a few things here. First of all, you'll look at gabapentin. So that's just a drug that's prescribed very commonly, and you can see that that's blaring, and caffeine is too. And so those are kind of our controls that we put in, and we like to see that this all makes sense, right? But let's look at norfentanyl for a minute. Okay, fentanyl and norfentanyl there. And so those levels are pretty consistent across most of the cities, and none of this is really unexpected. But if you look at the nitazines, remember I said those were the ones that we were asked to put in our assay because Indu's coordinating center was saying, God, we're hearing a lot of chatter about nitazines, and we think they might be circulating. And sure enough, we started to pick some of these up, a couple different ones. But if you look at etonitazine here, you can see we're picking it up at low levels, primarily in the West, Southwest, and East, but we're not really seeing it at all yet in Midwest. So what was really interesting is when we started pulling these layers back, something I didn't really know is that there's really different patterns of drug use that are regional across the US. And so why is that important? It's important because if you're going to do something with this data, I think it matters where you're measuring. We can't always make sort of large assumptions for the country if we haven't done measurements across. Right? If you look at methamphetamine, that one's always interesting to us because you can see this stuff is really high in the West and Southwest compared to some of the other regions. The deaths trends follow that as well, which is interesting. And then here's xylazine, that tranquilizer again. That was fascinating for us to see because there's a real hot spot for that, and that was on the East Coast. That's all the news was coming out. People were mixing xylazine with fentanyl. So it was really kind of nice to see that a lot of what we were seeing was matching what was in the news, what we were seeing trend-wise, kind of with more of the epidemiology based data. And then I'll just mention naloxone. So we were trying to take a look at, could we garner any information about what was going on with maybe what I'll loosely say here is interventions, right? And so looking at how much naloxone might be administered in an area and whether that would eventually maybe be associated with deeper levels of norfentanyl, fentanyl, And I don't know if that'll pan out yet, but it's interesting because we looked at naloxone, which you see here, which we see in some cities and not others, but we don't see any of the metabolite. And so this is now a problem of us not quite understanding biotransformation of the molecules or what happens to compounds in wastewater. Wastewater is a nasty environment, and so I think we don't have all the research done on compounds degrade in wastewater and how, can they sustain being whole molecules there for 2 hours or 4 hours or 8 hours or, whatever it is. And so we were pretty surprised not to see any of metabolite there. Could be a lot of reasons for that. Okay, so that was at one point in time, all that data across all that cities. We can look at this in a different way. So we can look across time. Well, and these are just 3 examples of the hundreds of graphs that we have. They're interesting, right? Because if you look at metabolite of methamphetamine, you can see now we have a couple different cities: Southeast, West, Midwest 1, and Midwest 2. There's a clear difference in what's going on in the western part of the U.S. with methamphetamines compared to the other cities. And remember, this is all normalized by population and flow. So this ran from spring of 2024 to spring 2025. So this is about a year's worth of data. And you can look at the other patterns here and see differences with acetylmorphine. They're a little more, tightly mixed together, except for the Southeast, which is pretty flat there. And then cocaine, which we're seeing really higher in the Midwest compared to some of the other regions of the U.S. And so there's a lot of fluctuation over time, but overall, the patterns seem to hold. Even though there's fluctuating measurements of methamphetamine in the West that go up and down somewhat, grand scheme of things, we're always seeing higher levels in the West than in other regions. Okay, I'm going to share, I want to talk a little bit about data harmonization. And to do that, I want to talk a little bit about something newer on the scene. And that is a recent release of information by the CDC that stated overdose deaths due to opioids decreased 27% in 2024. This is a big deal because this is the first time, I think, in 12 years that they had documented a decrease in opioid-related overdose deaths. So there was a lot of chatter about this. It was like finally, breaking in and seeing a decrease with all the efforts to try to combat this opioid epidemic. So we wanted to see if we had sampled wastewater kind of around that time. And so we also wanted to see if we were seeing a decrease in our cities as well. And so what we did is we looked across 4 of our cities, so Midwest 1, 2, Southeast, and West. What you're looking at here is fentanyl consumption rate over time, over the 2024 to 25, and the different catchment areas in the different cities. So in Midwest 1, you'll see 4 lines there. That's because we had 4 different catchment areas, 4 different wastewater treatment plants that we sampled. You can see the individual traces for those. You can see the average of those, weighted average, which is the red line in the middle there. A couple of things I'll point out is one is that you can see the levels between catchment areas are quite different. One catchment area is very high compared to the others, right? You can see these big peaks here. What was sort of interesting was overall, if you squint, you can see that it does look like there is a decreasing trend over time. We actually do regression-based statistical analysis, which I'm not going to talk very smartly to, is that we did see a very significant decrease over time, that line. We thought that was kind of cool, that we were seeing stuff that matched up what the CDC was saying. This is Midwest 2, which now only has 2 catchment areas, just 2 lines there. One catchment area showed a decrease and one did not. The one that did not has pretty low levels. The Southeast, which is a small city, so we weren't surprised to see we didn't see any change in that. It's kind of flat. The West is really fascinating because you can see here there's just one sampling site, but it has a pretty sharp decline early on in 2024. Seems to match what the CDC said. But then it seems to kind of start recovering a little bit. And so when we did our regression analysis, there was no downward trend for that line overall because we really only see it at the beginning, that sampling period. And then an article came out, and now several more have come out, which show, yes, we do see an overall decrease in opioid-related deaths in the United States. However, that is not consistent in every area or region of the U.S. What this article pointed out is that particularly in the Western U.S., we're actually seeing some upticks. It was very regional, where overdose deaths are continuing to occur. So we wanted to take a look at that a little bit more carefully, comparing our wastewater, particularly like in the Western region. We sort of saw that uptick, and Guardian reported that as well. I mentioned earlier that it's hard to get death data in real time. You just don't get it, right? And so data from the CDC can lag for 5, 6 months a year, right, before we have access to that. And that is data that's usually gotten from like medical examiners' offices and so forth. So it just takes time to get it. There's a new software platform on the scene, and this is called Biospatial. It is an expensive software program, but what it does is it collects data from states across the U.S. The caveat being states have to play into giving the data to this platform. A lot of states now do. So the data is getting better and better, but it's not 100% complete. Most of the data is EMS data, and it's at the county level. So what that means is we can capture EMS data in near real time. And so this is data that you get from emergency calls, for example, and fatal and non-fatal overdoses that are recorded and then sent directly to the biospatial platform. And so what's nice about that is we're trying to use wastewater as a rapid tool. And now we're trying to ground truth it with health data. Now we have some health data we can actually get our hands on in the same time frame, right? We're not having to wait 6 months to be able to take a look at CDC data. Not that we won't eventually, but it's nice to be able to see it in real time. The other, there's lots of different types of data in this platform, and it's really nice. You can search by county and demographics and all sorts of things. Pretty powerful. One of the things we were interested in is naloxone administrations and how well that they would correspond to our wastewater data. Maybe that would be a good surrogate to use, looking at whether we could ground truth it with what's going on in people, in communities. Okay, so I'm going to walk you through this. So I've already shown you this data. It just looks a little bit different. So that Midwest 1 city, I've taken one of the catchment areas, and that's what the trace of the fentanyl looks like, where you have kind of higher, we saw that significant decrease higher, and then it declines and maybe kind of levels off there, right? West looks different because it starts high and then it kind of rebounds, okay? When you take the CDC death data, it looks like it parallels what we're seeing. We're seeing a decrease in the Midwest with death data, but you see we can only get death data up until this. We don't have the rest of it to fill in. That's due to that lag. We then took a look at was naloxone data was already up to real time. So we were able to look at naloxone administrations, and which seemed to parallel very nicely we were seeing in water data. And so we've done some statistical analysis on this. We need to do more. They correlate very well together. And so we're thinking this may be a good way for us to be able to ground truth our wastewater data in the time frame that we want to do it, without having to wait for all the death data at that time. If you look at the West, that's the CDC death data, which is kind of flat, which is interesting. And then this is on a little bit of a different scale. There's a lot more fentanyl in the West, but you can see that there's a dip and it's starting to come back up with naloxone as well. And so there was a nice correlation between these two. So I don't know if this is going to pan out, but we're trying to look at this harmonization. It's an example of that in this way. Otherwise, we're just doing a lot of measurements and we can see trends. But is it really tracking with what we're seeing in the actual people in the communities? So we're really fortunate to be able to have access to this software. So at least we can start this process and figure out what might be a good way forward for us to be able to do that. And one thing I will say is that several articles have now come out saying in the Western, especially northwestern part of the United States, that there is a rebound of opioid-related deaths. So what we were seeing there really held true, CDC data. Okay, so I'm going to shift gears just a little bit. So I'm going to get away from some of the measurement stuff, right? And I'm going to talk a little bit about what we might do with some of this data, but also some of the challenges we've encountered in this part of the framework. How do we disseminate data to our stakeholders and what can or should they be doing with that? For a lot of the dashboard work, we partnered with a company called Xylem, an engineering firm that actually takes the sewer network and uses that as an anchor. And so they built the dashboard for each one of our cities, which is really cool. Show you in just a minute a example of what one of those looks like. But I just sort of want to remind you of what this framework looks like. So up until now, I've really talked mostly about all of this part through the detection, right? So it's all measurements. They actually don't mean a lot unless you actually do anything with them, right? So we have the dissemination piece, and I put this dotted line here instead of a solid line because I feel like we're not quite there yet on how to do this piece really well. We can measure stuff really well, and I'm really confident about that. But how do we set up these partnerships in a way where this data is really useful for people? Otherwise, it just sits in a folder somewhere, the Department of Health, and they don't use it, right? So spent a lot of time having conversations about that with our stakeholders. I'm going to talk about 4 challenges to this part of the framework. You don't know what you don't know. You don't know because I haven't told you yet what that means. So I'll tell you in just a minute. Talk about stigma and ethics, data control, ownership, and how anonymous data needs to be. And then talk about a little bit of the difference between surveillance and research and what some of the needs are that I think need to happen. Okay. So I mentioned that when we first started this project, I had a team of 30 or 40 stakeholders, all different people from departments of health. They're from all different states. And when you're going across states, it's really fascinating because they have their own ways that they think about and do things. And so pretty naively did all these measurements and had all this data, and we were all excited and we gave them the data. And we said, well, what do you want it to look like? And what are you going to do with it? And they said, we have no idea. So we spent about 2 years on this dashboard and really an iterative process. And so what you're seeing here is this is a city where we have like 4 different catchment areas, right? 1, 2, 3, 4. And so every week we would put in new data, and the colors represent how low or high the level of a drug was. And you could toggle to your favorite drug. This is norfentanyl. Okay. I think the red, I know my glasses on up here, the red's the highest, the purple's the lowest, so these are low to moderate levels, but you can see that this region here, this central region, has higher levels than the other region. Okay, so you can tell that from this. But we would then give them this dashboard and say, go play with this. And then we'll meet a couple weeks and you tell us what you like about it, what you don't like about it, what data is missing, what else you need to know. It was a really eye-opening process, I think, us and them, because it really forced them to sit down and think about how can we use this data? What other information do we need to be able to use it? And using it can mean a lot of different things. It could be like really pointing them to the areas where they're seeing more or less drugs. It could be like maybe we'll try an intervention and then we can see if it's working using wastewater. So like one of the questions, just to give you an example, was what is a high level of fentanyl in wastewater? I mean, there's nothing out there that says this is a low, medium, or high level of something. So we started doing what, statisticians and epidemiologists and toxicologists, we break things into quintiles, right? And so we started doing that, and that was fine for each city. But something that was really valuable to the people looking at this data was, well, can we see how we compare the other cities? Although we can't share what the other cities are, so it's complicated. But what we did was we put a toggle bar at the top. I don't know if you can see that. It says national or local. And they could toggle this dashboard between local and national, and it would show them how their levels compared locally over time, because we're compounding this data every week, or they could toggle to national and see how their levels compared to national, not national levels, other cities that we were measuring, right? So that ended up being an extremely useful tool for them, because then they could talk about the levels of the drugs in their regions in the context of not only just their state, but other states across the US. There's all sorts of other bells and whistles we put in, but that were really valuable to them, which I don't have time to go over. But it was a really, really good process and gave us really a good understanding of how they needed to be able to see and play and analyze this data. Mention a few things about stigma and ethics, because I think it's really important. It's important in public health, period. But we have extra layers of challenges when we're looking at illicit drugs in this space. A really good example is a study that they rolled out in New Mexico a few years ago. And I think the study was a very well-intended one, and they wanted to be able to test all schools across the state for illicit drugs. But there was a lot of pushback on this. For one, because the students are minors, so there was concern about that. But this is a podcast and there's a transcript. I just wrote this word for word because I didn't want to misstate it. But some of the critics had these things to say about this study. No one at the state level had said what they plan to do with the information. People were confused, didn't know what was going to be done. People get worried about law enforcement coming after them when they're testing for legal related activities. Okay. There's a risk of stigmatization, and the community already typically has some other overlapping stigmas. So we're just now adding another stigma on top of that to be able to say, okay, this community has all of these things going on in it, and now we're just saying things that people probably already know, but it is kind of stigmatizing them, which leads to all sorts of issues with public health trying to be helpful in those communities. And so really at the end of this podcast, the conclusions was communities should know about the testing and have a say in the response to it. Evidence-based approach is a community-based one, and the solution should come from the impacted people. So we've seen this many times with working with opioids in these cities. We've had cities that have not worked with us because they just couldn't figure out how they could do this. It made us really think about these wastewater-based studies being really community engaged ones. And when you're doing a community engagement study, you have to engage the community at the beginning. And that's something that I think the opioid space really needs to be done and thought about carefully. Data ownership, who owns the data? That depends on who you ask, right? If you get a federal grant and you're at an institution, your institution owns data, right? That's not how many departments of health and other stakeholders see it. And so we have gone round and round with different cities. Some cities are right on board with everything. Other cities have said, after a year of measurements, we've decided we can't be in this anymore because we need full control of the data at the Department of Health. And that wasn't going to happen. Right? So I think it's really important to get all of these things worked out front. Otherwise, you're wasting a lot of time getting numbers that go nowhere. Right? And so we have pretty transparent but detailed MOUs that we now make with all of our partners up front, so everything's clear. We make concessions. I haven't said one thing to you about where these cities are today. And I won't, and because I've promised them I would not. If I publish it, it's going to get published like this. I'm not going to name cities, and so we do agree with certain things, and we compromise. And I think there's a really good reason for doing that, but it has to be clear up front. And then the last thing I'm just going to mention is we're at a point where we've been doing really surveillance for the last few years, and all the money that we've been getting. We've been continuously funded for 4 years to do this, but surveillance work, and it's not necessarily research. Researchers at the core, we're academics, and I do think that there are a lot of research questions that still need to be answered in order to make this framework more rigorous from a scientific standpoint. And I've just put some questions here that we think about, like how often should sampling be performed? We have to do it once a week because that's a lot, but maybe we can do it less times than that and still get the same information, right? You really need to set up research studies to be able to do that. I talked about compounds degrading in wastewater. Can we use wastewater-based epidemiology to determine if interventions are effective? And I think that takes research. So I think we're getting a little traction. At NIH, I'm seeing some more wastewater stuff come through the pipeline. So hopefully we'll be able to get some research funded in this space, in addition to doing surveillance. Surveillance is really important, but I think we should be doing both. Okay, so my final thoughts. Wastewater-based epidemiology gives public health a powerful new lens, one that is rapid, population level, and I think potentially actionable. I think data alone, though, are not enough. Ethical use, transparency, community engagement, and clear data ownership are essential to make this a functional framework. Just really talked about surveillance and the importance of research, but I think if it's done right, I think this tool can be around and be very useful to the field of public health. And I am going to thank my many collaborators on this project. University of Florida is really where this started and where they're doing more the measurement side of things. There are probably 40 or 50 names that should be up here that I've just put down at the bottom as stakeholders because I can't share their names, but I thank them. They've been really instrumental in pushing us forward in trying to make this work. And of course, our funding agencies, NIH, most of the work I talked about today. We also have another project where we're doing surveillance across the Mexico-US border. That's funded by NDCP. So I will stop there and open for a discussion. If anybody has any questions?
Thank you for a very informative presentation. It really challenged us intellectually on some of the parameters of this data and supervision. The cities that you have included represent the various geographical regions.
They do. So when I say east, it's all the way east. When I say west, it's all the way west. And then the Midwest, are in the middle. But yes.
I didn't understand that the trade in illicit drugs is actually very regionally
Right.
influenced.
Right.
The reason I ask that is it does seem like trends in substance use are influenced by supply and demand dynamics.
Yes.
You try to plot your data with whatever data is available on supply, arrests, sometimes year of confiscation of very large deposits of substance in warehouses, things of that nature.
Yeah.
In order to give us more insights into the, it's hard to say autonomy.
Yeah.
User in what substance they use.
Yeah. That's absolutely true what you're saying, and we've had a lot of conversations with ONDCP about that, and particularly the project where we're looking at border crossing is we're trying to understand traffic of it and then where it goes. I've seen some maps that ONDCP has, and it's like, across the U.S. stuff comes in and then it goes here and it goes there, and it's really complex, actually. We haven't taken our data and the study I just talked about here and mapped that yet, but we've talked about, doing that to see if that's another set of data. So there's multiple data sets we're looking at. That's one of them, more on the trafficking side of things. But there definitely are regional differences, and a lot of it is driven from where stuff comes in and what's available. And these pathways of trafficking, if you will, are pretty set in many ways, and so where things are going.
I have two questions. One is kind of a more big picture question, and one is more specific about the sampling. So the first is, I think we all can agree and understand the importance of community engagement and like kind of public ownership of this type of sensitive data. So how do you sort of, cross the two ideas of maintaining anonymity with public ownership of data? And I guess like by public, if you can kind of clarify, who you think it should be in charge of and owning this data. Would it be like local public health organizations or, actually community members? And then sort of the challenges with anonymity.
I don't think the ownership should be community members. I think an ownership should be shared in some way, and I'm not talking about ownership as defined by the university or that, but, how we analyze and use it is to be shared. And I think a lot of it has to do with the agencies and departments of public health, for example, and they're the people that message things typically, or city officials, I guess. When we have measles and when we have, all these things going on. And so where we've run into issue there is they push back because they've been in bad spaces before. you know, the dean and I were just talking about one in his office, you know, where something gets messaged and it just goes left or, you know, goes the wrong way. And then you have a lot of community, you know, pushback on that. And so like a couple of our cities were like, well, we're going to work with your risk communication people. And they're like, we don't even want to do it. It's too much of a risk, you know? So I think we need to get the communication experts on board. I mean, I'm not a communication expert, so I don't know how to best message this stuff, but the people that are, and what they have to do is win over the trust of the community. And so you need trusted people to be communicating this stuff. So when they hear things about wastewater, they're not going, oh, they're coming into our neighborhoods and, you know, the law enforcement's going to now be here and all of this other stuff, right? So I think it's tricky space. I think educating people about it at the start can be helpful, but you need all these agencies on board. I can't just go into a community and say, okay, wastewater's great. You know, I need all these agencies to back me, be able to do that, or they should do it, or we work with community partners to do it, right? Because then the message doesn't get twisted because they have some information. But it's really challenging, and it's really fascinating across the states, which states are like, yeah, we're going to do this, and we don't really need to be that anonymous. And other states are like, "Oh, we're not touching this." You know, it just really depends. And I think some of it, at least in my opinion, data to support this, but it's through conversations, that it sometimes depends upon their history of, you know, like one city was like, we did wastewater for COVID, and it was a huge debacle because the community got upset and why are we doing it and all of this stuff. So when we came to say we want to do opioids, they were like, oh, we had such a bad experience already. So I think that plays into it too. And I get it, because if you're getting calls from the community and people are pushing back and people are not listening to prevention advice or whatever it is, it's a problem, big problem. And so they don't want another problem, you know, even though the data could be useful, right? They don't, the risk is too high. So I don't have great solutions, but I think all the players have to line up there, and I think the risk communication people have to get people.
So the other question I had is about the sampling. I don't know anything about wastewater. So when you're collecting it, is it like a homogeneous mixture? Because I'm just wondering if it depends where you sample from, you know, if you're just gonna get so much noise and hard to pick up a signal.
Yeah. So there's several ways to sample water in general. One is called a grab sample, which is just what it sounds like. You know, dip your jar in and take a sample out. Usually stuff won't be quite as concentrated enough to measure and not as homogeneous enough, you know, to your point. So usually we do 24-hour composite samples, you know, or 12-hour or 8-hour, you know, where there's like a device that we kind of put in the wastewater treatment plant, and it captures water over time. And when we do that, it sort of gives us a good, you know, more homogeneous or heterogeneous mixture of wastewater coming through. Yeah, we do it. You do it that
way. A lot of like air sampling.
Yeah. It's similar. A similar way to think about it. Nice.
Sure.
Well, first maybe in back and then Suzanne.
Suzanne, I was just wondering, when you are successful at convincing places to go in, what has worked?
Yeah, so I could tell you, for example, like Tempe, Arizona. I can say that one. I forgot. Yeah, they did a real big community-based effort when they started doing this. And so they had like community events where they said, we're going to roll this out and this is what we're doing and this is what it means. And they actually have a dashboard up. Or they just have like 5 drugs, but they're doing sampling. We're doing sampling with them. But it's been accepted by the community, and that you can go look up that data right now. It's there. So people have made it work, but I think you got to start right at the beginning and get all the buy-in, all the people that need to be involved, and then it can be successful. I think it becomes a little bit harder the bigger the city gets, I mean, so some of our cities are very large, which means there's multiple strings that need to be pulled with respect to agencies. And so that it's another level of challenge, but it's doable. It's doable. And we did it we were doing SARS-CoV-2. We had a small rural conservative county and they wanted to do some work with COVID. It was sort of an isolated island in Florida. But we did the same, we had some community meetings and got everybody on board and we were able to do it. So it's doable. I think you got to really have this kind of community-based approach. I think he was next and then I'll come.
So, what I'm trying to understand is the results of your data. I can see how that can benefit the public officials. How does it benefit the community members directly?
Yeah. So, I mean, I think it's really like a public health benefit, right? So in communities where you have public health issues, like a lot of illicit drug use, I mean, one of the goals is to stop that, right? And lessen it. And so communities are better for that, certainly. So, I think that's inherently benefit. It's like we're trying to make communities as healthy as we can as public health practitioners, right? And so this is just, it's not going to solve everything, but it's another tool to add to the toolbox to help us kind of get there. So I don't see this as like, oh, we're going to go measure stuff and there'll be some intervention and then we're going to not see any opioids, anymore. But I think it could help push us in the right direction by showing us where we should be doing those interventions, whether the interventions are working in kind of a rapid time frame.
Just need to add one thing to that. In answer to your question, that at the community level, data is useful if it is at the micro level, meaning smaller populations, studying smaller populations, and looking at comparability, because communities are not able to discern large data sets looking even at neighborhoods. Even during COVID, when we're looking at Harlem as a neighborhood, we found important differences between West Harlem, Central Harlem, and East Harlem. So microdata is much more useful at the community level than larger population. If you're talking about action, advocacy, intervention, education, you can't really use that data very effectively for these purposes.
Well, that comes to a question that somebody has asked on the
Okay.
which is there do you have some evidence of a city that used the data to evaluate the effectiveness of an intervention?
We have not yet. No, not that I know of, unless they have the data and they're doing it. We have one city in particular that's really cooperative, and wanting and sharing data and so forth. And they've been mostly interested on the, I guess, more research side, trying to hone the framework before they do interventions. Like how often do you need to sample? Like that's a big question for them, because they want to stand up wastewater in their city, their Department of Health, which they've done now. So they've done that, but they still have a lot of questions as do we have to have all the resources to do this every day, every week, or can we, sort of space it out and have it still be very effective? So I think people are moving in that direction, but I think we're not quite there yet with understanding exactly what all the data, mean. So as far as I know, we haven't seen it with our cities unless someone else has done something, but I do know that we want to try to set that up. I know that city's trying to move towards setting something up.
Which I think goes to the issue of data sharing.
Yeah.
We also, writing a proposal right now for NIH. And of course, there's a data sharing section where you have to explicitly
Yeah.
state how data will be shared.
Yeah.
And so that's a challenge that you have, because if a city wants to see if there's a change based on a needle exchange program that they institute, are they able to, you have to give them the data. That's sort of your NIH obligation to.
I have had more conversations with NIH about this project because we got stuck when we started this because of this, where we were like, if we share the data, we're going to lose all our partners. We have no study. So what should we do? And we had to really talk through stuff, to figure out how do we get to a space where it makes sense. And so we do share data, but we don't say where the city is. That's kind of where we ended up. It's tricky space because every agency has their own set of rules about data sharing, right? And those don't make sense for all parties involved. Somebody think.
So it seems to be like there needs to be a lot of buy-in on a community level before you can even go in and begin doing research. For that New Mexico school study, how was it possible that they were able to begin the research and like the community had no idea what the data was going to be used for? I would think that would need to be a conversation that would need to be had beforehand with the community before, or is that a common situation or a common thing that happens?
I mean, I think in this space it hasn't been common. I don't know. That's what I would say. But it maybe should be more common. In that case. And so that looked to me like it was like, okay, this wastewater is a good tool. It can be really useful. Somebody decided at some level this was a good idea to allocate resources. It's the other thing. That study cost $600,000 to run. And so there was a lot of pushback on the financial side of that as well. Like, why are we spending, what are we doing with the data? We now know what we already knew, which is, we have teenagers, using illicit drugs in schools. And so there was a lot of like, so what, that study, right? It was so the value of it was not to be communicated. Yeah. So it's hard though. So it's like, how do you, you want to run a study, but how long do you take to roll stuff out in a community, and who are you telling? And in that case, who are you telling? Are you messaging all the parents of the schools, or, so,
This is an example of hyper micro data that we're talking about. Very hyper micro, very, very small if it's a school district, for example. And I think this data is very valuable if it is data over other social, political, economic,
yes.
and anthropological data. It's not, I mean, if you find that in a school, people are using illicit substances more, in of itself, it's just a data point from a public health perspective that has to be, if it's useful, linked to other kinds of data to make valuable sense. Sorry.
Sorry. So just we're talking about the value of micro versus macro level data on this, and that maybe it's more useful, the smaller the community might be, but I know that you're looking at generally wastewater treatment plants and maybe also some like quite local collection where you're going into the manhole. And is there a certain population density that you look at when you're looking at your sampling point? You kind of touched upon this, just where the sampling takes place. You have to kind of think, are we near veterinary centers? Are we near
Right.
hospitals? Can you talk a little bit more about how you select your like collection points?
Yeah. There's whole bunches of ways you can sample, and that's another big research question: is how big is too big? How small is too small? That side of it as well, right? We have the capability to get pretty granular, neighborhood levels, the building levels. The question is that useful? Is it useful on its own? Is it useful in the context of other harmonized data, right? But I think that's where we need research as well to really say, like we've been talking a lot about, what is the model sampling scheme to do this well? How often do you have to sample? Where do you sample? How granular does it need to be? I agree. Doing 1 million people is like, okay, but it's really more of a proof of concept in this case. And we also know fentanyl's all over the place, so that's not a surprise, right? But I think those are really important questions. I think the contribution when you're looking at fentanyl of medical waste is important. Even though we've done some calculations with prescriptions and it looks like it's a small amount of contribution, it'd be really nice to ground truth that you could go upstream from a wastewater treatment plant and sample up back to hospitals or other, flex points in the sewer network. And we've done some of that on some of the Southwest cities. I think some of the data I showed was actually captured in actual sewers. Now, there's some challenges to that too, related to flow. And so you have a lot of flow in a wastewater treatment plant, but even when we were doing COVID in the dorms, like you only have flow when people flush the toilet, right? And so sometimes you go to sample and there's just not a lot of material there sample. So you got to get kind of creative with samplers that kind of leave there for periods of time and collect for periods of time. And so, I don't have the best answer for you, but it's doable. It's just, we need to really do the studies to figure out there's a difference between 1,500,000, 100,000 in the sewer network in the neighborhood. We'll say with opioid work, the more granular you get, the more tricky it gets, because now people are really concerned about being identified. And, so that's one of the reasons we just stayed big to start with, was to try to avoid any sense of, I'm going to be tracked down and arrested, which won't happen. But I mean, people don't really fully understand that.
I'm going to follow up with just if there's any thoughts of, concerns about more rural communities, but that would then lead to questions of anonymity and confidentiality. I suppose if you wanted to speak about that, or
Well, one of the challenges we have in rural settings is we're working on municipal sewer systems here.
Yeah.
And a lot of rural areas have
their
septic tanks. So the only way to sample there is to go in the septic tank or the line coming out of the house, but then exactly, so that becomes a problem, right? So that is a challenge in rural areas. Yeah. Somebody had
We have a question from our online participants.
Okay.
We have a few actually, but one of the questions asks, if you're familiar, can you speak on the weaponization of this monitoring method by legislators attacking access to birth control?
access to what?
To birth control.
Control.
You mean testing wastewater for evidence of
Birth control?
Yeah.
Oh.
At least in Texas, but I'm not.
So like measuring other things for other purposes. Is that Yes, yes, yes. Oh, jeez, that's a question. Yeah, I mean, it's, hopefully it doesn't come to that. There's many other things right now. Um, but I'm not even sure that makes sense, right, to do. So you're I've heard of these cases where we're going to try to measure X, Y, and Z, and then we're going to try to go get people that are doing X, Y, and Z. And so, I mean, the issue with the wastewater is unless you're sampling granularly, most people don't because it's really hard to do. I don't know how you get granular enough to do anything. So I'm not sure that will come to fruition. Um, but yeah, it's not really a good thought, is it? Actually, yeah. Yeah, I don't have a great answer. Except for the wastewater is not really widely accepted for things right now, other than probably the pathogen stuff. This has some traction because of COVID, but measuring other things like drugs, it has a lot of traction in other places around the world. Actually, in Australia, they've been doing it for over 20 years. They have a whole national level surveillance system that just runs and runs and very successful. But I've had a lot of conversations with those folks, and a lot of what gets applied there and works is just difficult to implement here. I think one of the reasons for that is just the way we're set up. We're just a massive country with all these states that do things all differently. There's a lot of cultural differences and all sorts of things, political differences. And so I think it's just the nature of who we are in the United States just makes it a challenge.
I think we have to stop, but
Okay.
thank you.
Thank you so much.
Presentation. I think all of us are thinking about these issues. So
We could solve some things for me. Thank you so much. Appreciate it.
thank you.
Just want to give a special word of thanks. You are one of the deans of the schools of public health. Actually, we are very, very proud during the year of 10th anniversary to invite some deans from other formidable school of public health, the University of South Carolina. Very well-renowned school, the large research portfolio, and a long history. Schools like this are resources that we can learn from to make ourselves better and improve our curricula, then create new partnerships, giving us the time as a team, coming all the way to you.
My pleasure. So